Hi everyone, hope you all are doing well. So today we'll be starting with yet another first aid review, and the topic is, or the chapter that we'll be doing is the renal. So as usual, you can watch the videos along with the first aid and annotate as and when. Also while revising the videos, watch it on a 2x for a super rapid revision. If you want the PDF, you can DM me on my Insta channel, the link to which is here and also in the description. And to access the previous video, click on the link in the description box below. Right, I have included my personal notes as and when required so that it helps you to give a better correlation. Also, you can make your own notes and add in info as and when you find relevant, especially for the topics which are volatile. So let's dive into renal, and we will begin the today's session by talking about the renal embryology. Look at this diagram. You can see that there is pronephros, mesonephros and metanephros, right? That is taking place in the development of the kidneys. Pronephros is seen during the 3rd week of development. The mesonephros is seen during the 4th week, while metanephros is seen in the 5th week of development. So what happens is that the pronephros, it degenerates. The mesonephros, it functions as an interim kidney in the first trimester, right? And then in the male fetus, it will persist as the Wolffian duct. While what happens is that the metanephros, it is a permanent structure, and it is what is responsible for the formation of future kidney. Talking about the development of kidney, which is also called as nephrogenesis. Right, so it is completed by 36 weeks period of gestation, and the kidney develops from two parts. First is the ureteric bud and second is the metanephric mesenchyme. Right, so ureteric bud, it is a metanephric diverticulum. It is derived from the caudal end of the mesonephric duct. So this is the mesonephric duct, and the caudal end of it leads to the formation of a ureteric bud, right? So the ureteric bud will lead to the formation of ureter, the pelvis, calyces and the collecting ducts, right? It is fully canalized by 10 weeks, and if there is any problem with the canalization, it may lead to anomalies. Like for example, the pelviureteric junction is the last to canalize, and if it does not canalize, it leads to the obstruction of the pelviureteric junction, which we also call as PUJ obstruction, right? And PUJ obstruction is the most common cause of prenatal hydronephrosis, right? We'll talk about it in detail later, but you need to know this basic thing before diving into the details of PUJ obstruction. The second part is the metanephric mesenchyme. It is also known as the metanephric blastema, right? What it does is that the metanephric mesenchyme interacts with the ureteric bud, and this interaction is what causes its differentiation, and it leads to the formation of the glomerulus right up to the distal collecting tube, right? Collecting duct is formed by the ureteric bud. The filtration part of the kidney up till the DCT is formed by the metanephric mesenchyme, while the collecting part, or the part from the collecting duct up till the ureter, is formed by the ureteric bud. Now, if there is any aberration or abnormal interaction between the metanephric mesenchyme and the ureteric bud, it will lead to congenital malformations like renal agenesis, right, medullary cystic kidney disease, and so on. So this was the basic development. Now let us look at some of the congenital anomalies, right? So the first thing is the Porter sequence, which we even discussed in the reproductive section. So what happens is that if a female has oligohydroamnios, that is decrease in the amniotic fluid, right? Because oligo means less, hydro means water, and amnions means amnion. So the fluid in the amnion, which is the amniotic fluid, is less, that is oligohydroamnios. It will lead to compression of the fetus. So imagine there is less fluid, so the fetus would be tightly packed inside the uterus, right? So there is pressure on fetus from all the sides. So what happens is that due to this there is facial anomalies. Like for example, there will be low set ears or retrognathism, that is the jaw moves backwards, right? Retro means backwards. Like it is always easier to remember stuff when you break it into two parts. For example, here retrognathism, like nas is jaw and retro is back, right? So backward moving jaw, this is retrognathism. The ears will be low set, right? And since there is compression, the nose will also be flat. There is compression on chest as well in this case, and the compression of chest will lead to pulmonary hypoplasia. And remember, pulmonary hypoplasia would be the most common cause of death in a baby that is suffering from this Porter sequence. Now, the causes for Porter sequence can either be a chronic placental insufficiency, or it can be due to a decreased renal output in conditions like autosomal resistant polycystic kidney disease, right? Obstructive pathologies like PUJ that we just discussed, and renal agenesis. So what happens is, in all these cases, the kidney is not functioning. The kidney is not functioning, so it will lead to decrease in the production of amnion, right? Because amniotic fluid is nothing but fetal urine after 20 weeks of gestation. If there is less fluid, there will be compression leading to facial anomalies and pulmonary hypoplasia, right? Facial anomalies were like low set ears, retrognathism and flat nose. So remember the difference between Porter's sequence and Porter's syndrome. So Porter's sequence is a milder kidney pathology like a pelvic-ureteric obstruction that is leading to pulmonary hypoplasia, while Porter's syndrome would be a severe renal condition like bilateral renal agenesis, and Porter's syndrome is not compatible with life, while the Porter sequence babies might survive. How do you remember is that there is a very good mnemonic given in your first aid, right? That is, babies who can't pee will develop the Porter sequence, right? Very easy. And its associations are remembered by the mnemonic Porter, that stands for pulmonary hypoplasia, oligohydramnios, twisted skin, only one T, then extremity defects and renal failure in utero. So that's Porter sequence. The next congenital anomaly is the horseshoe kidney, right? So here what happens is that there is fusion of the inferior poles of the kidney, right? Looking at the CT image, so this is the vertebra, so this would be posterior, anterior, right? This is the liver, and here is the IVC, and this is the aorta. So how do you see? IVC is a vein, it is always on the right side, while aorta will be on the left side, right? So this is always right, this is always left, anterior and posterior. This is the orientation of the cross section. So here we can see right kidney and left kidney. Now notice that both the kidneys are fused at the inferior pole, right? So this is what it is, the horseshoe kidney. Why it is called horseshoe? Because it resembles the shape of the horseshoe, that is, you know, like dug into the hooves of the horses. Therefore it is called as the horseshoe kidney. So due to this abnormal fusion, what happens is that the kidney are unable to ascend up, right? Metanephros is situated deep inside the pelvis, and after the development, the kidney ascends upwards and takes place in the renal fossa. So due to this fusion, what happens is that there is problem with the ascent of the kidney, and why this happens is because of the presence of inferior mesenteric artery. So this artery is present, and this will prevent the ascent of the kidney up in the abdomen. So here the kidneys are normal per se, but it may be associated with hydronephrosis, right, stones, and increased risk of infection as well as cancer. The horseshoe kidney is also most commonly seen with some aneuploidies. On IVP, it has a characteristic appearance called as the flower vase appearance. The next congenital anomaly is a congenital solitary functioning kidney, right? And the causes that lead to the formation of a congenital kidney can either be a unilateral renal agenesis or a multicystic dysplastic kidney. So, renal agenesis is due to the abnormal formation of the ureteric bud, right. So, if there is no ureteric bud, so there will be no induction of metanephric mesenchymal differentiation. Hence, the kidney would be absent on the side that the ureteric bud is absent. While in a multicystic dysplastic kidney, the ureteric bud is present, but there is no induction of differentiation of the metanephric mesenchyme. So, that is the difference between the two. In both the cases, only a solitary functioning kidney would be present, right. Then the next topic is duplex collecting system. So, duplex means that there will be two collecting system, right. It is basically due to the bifurcation of the ureteric bud before it enters the metanephric blastema. Right. So, because of this, what happens is that there is a presence of a Y-shaped ureter. It is also associated with vesicoureteric reflux, obstruction, and increased risk of infections. On IVP, the appearance would be a drooping lily sign. Right. The next congenital anomaly is a posterior urethral wall. So, here what happens is that there is a membranous remnant in the posterior urethra, in the males obviously, and that is the prostatic urethra. So, the persistence of this membrane in the posterior urethra, it leads to the back pressure on the bladder and as well as the ureter, leading to the vesicoureteric reflux, right, bilateral hydronephrosis, as well as thickening of the bladder wall. Compare it to the normal side. See, the ureter is dilated, right, the kidney is also dilated, that is the pelvis is dilated, and the calyces, leading to hydronephrosis, as well as the bladder wall is thickened. On MCU, it will present as a keyhole defect and it can be detected on antenatal ultrasound as well. It is the most common cause of bladder outlet obstruction in male infants, right. So, for posterior urethral valve, a Young's classification is there, which divides it into three types. First is the most common, where the membrane is present below verumontanum, right. Second is posterolateral position of the valve, and third is a Cobb's collar. That means that the valve is circumferentially surrounding the urethra. For management, the surgery is Anderson-Hines, pyroplasty with the Boari flap repair. What is a Boari flap? That is, a flap from the bladder is raised and it is used for the reconstruction of the ureters. After PUB, the next anomaly we will be studying is the VUR, that is what? Vesicoureteric reflux, right. So, it is nothing which we saw, it is the backflow of urine into the ureters, right. It can be either primary or secondary. The primary VUR is usually due to abnormal insertion of the ureters, while the secondary is due to increased pressure of the bladder, right. We as secondary to posterior urethral valves, there was increased pressure causing VUR. Now, VUR is associated with increased risk of UTI infection. Therefore, prophylaxis with antibiotics is done in case of a VUR. For grading of VUR, there are 5 grades. Right. In grade 1, there is minor reflux into the ureters. In grade 2, there is reflux into the ureter as well as the kidney. In grade 3, there is reflux along with minor hydronephrosis or swelling. In 4, there is major swelling, and in grade 5, there will be severe swelling with a tortuous ureter. Right. For stage 4 and 5, the management is a sting procedure where what we do is that we inject suburethral, that is suburethral injection of Teflon. Right. For prophylaxis of vesicoureteric reflux, the procedure is Leadbetter Politano. Next is a retrocaval ureter. So here what happens is that during the development, normally the IVC is present and the ureter passes in front of it. But due to any abnormal development, if the ureter passes behind the IVC, right, this is called as retrocaval ureter. So since IVC might lead to compression, it causes hydronephrosis of the proximal part, and on IVP this appears as the classic fishhook deformity or the reverse J sign. Right. The next condition is polycystic kidney disease, which can either be autosomal recessive or autosomal dominant. The autosomal recessive is seen in utero and it is incompatible with life, while autosomal dominant can be seen in adults as well. We will discuss more about it in the topic renal cyst. Right. So now let us move to our renal anatomy and briefly discuss it, which is important to understand the various pathologies as well. So now the kidney, it is made up of cortex and the medulla, right. There are renal columns of Bertini, which is in the medulla. Then it delivers the blood to the calyces, that is the minor calyces which form the major calyces, and the major calyces forms the pelvis, and pelvis will take the urine to the ureter. Right. The vascular supply is by renal artery, which divides into segmental artery, interlobar, arcuate and interlobular artery. This is easy. First renal will divide into segmental, then interlobar के बाद arcuate and finally interlobular. So why this is important is that because nowadays the renal Doppler is being performed extensively due to the increase in incidence of hypertension in young patient or as well as in older patient for the condition of renal artery stenosis, right. So what happens is that in renal artery stenosis, you put the probe on the segmental artery and you get a waveform. So this is suppose the normal waveform. What happens is that in stenosis there will be Parvus-Tardis waveform. Right, this is similar to the aortic stenosis pulse, that is pulsus parvus et tardus. Similarly here as well on the Doppler, due to stenosis of the renal artery, there will be a Parvus-Tardis waveform. Now what happens is that the interlobular artery forms the afferent arteriole that delivers blood to the capillary called as the glomerulus, right. Glomerulus is in the Bowman's capsule, right. Then from the glomerulus arises efferent arteriole, and the efferent arteriole gives rise to the peritubular capillaries. These are the peritubular capillaries which will lead to the formation of vasa recta as well, and we all know that vasa recta is responsible for the counter current mechanism in the kidneys. right? Now for draining of the blood, the vasa recta will drain the blood into the interlobular vein, again the same as artery, arcuate vein, then interlobular vein, and finally the renal vein. Now we already know that the left renal vein is longer than the right renal vein, and it is drained by two extra veins, that is the left suprarenal vein and the left gonadal vein. Since it is longer, left renal vein is preferred for living donor transplants as well. Another point to note is that the medulla receives less blood flow than the cortex. Therefore, medulla is more sensitive to hypoxia. So, in cases of hypoxia, the kidney will secrete hypoxia inducible factor, right, due to medulla sensing it before the cortex, and this leads to the increase in the production of erythropoietin, leading to increase in the RBC production. After talking about the macroscopic anatomy, let us look at the functional unit of the kidney, right, the glomerulus. So here we can see the cross section of glomerulus showing the afferent arteriole, right, forming the glomerulus, and finally the efferent arteriole. Then there is the juxtaglomerular apparatus along with the endothelial and the mesangial cells. Then the Bowman's capsule, it has parietal layer and a visceral layer. The visceral layer has foot-like projections which is called the podocytes, and it forms the slit membrane of the kidney, right. Compare it to the histopathological image. So this is the Bowman's cup consisting of the urinary space or the Bowman space, and in between we can see the tuft of capillaries which is the glomerulus. So you can see the endothelial cells, right, as well as the mesangial cells. The pink substance that we can see are the mesangial cells, while the lumen and a nucleus is the endothelial cells along with the endothelial basement membrane, right, and adjacent to it we can see the distal collecting tube and the proximal collecting tube. So how you can distinguish between DCT and PCT is that the lumen of DCT will be larger while the lumen of PCT will be smaller. The visceral and parietal epithelial cells are not seen on light microscopy. For that we use the electron microscopy, which we will see in a while. Before that, let us look at the course of the ureter, right. So what happens is that the glomerulus and the Bowman's cup is responsible for the filtration of urine. The urine then reaches the proximal collecting tube, after which it goes to the thin descending loop of Henle, and finally the thick ascending loop, right. Then the distal collecting tube, and finally there is collecting duct. From collecting duct, the urine reaches the pelvis, right. Collecting duct will open into the calyces, and the calyces finally leads to the drainage of urine in the pelvis, right. The pelvis gives rise to the ureter. The ureter finally opens into the bladder, right. So for the course of the ureter, what is very important to know is that water under the bridge. So water, that is ureter, it passes under the gonadal vessels, that is the uterine artery and the vas deferens, right, while it lies over the common iliac artery. So what happens is that in gynecological procedures like ligation of uterine artery or the ovarian vessels, the ureter might also get damaged, which leads to obstruction or leak, that is the urinary leak. Now the blood supply of ureter is by renal artery proximally. The mid ureter is supplied by the gonadal artery, and as well as the direct branches from aorta, common iliac and internal iliac artery, while the distal ureter is supplied by the internal iliac artery as well as the superior vesical artery. And the most common sites of ureteric obstruction would be the uretary-pelvic junction, then the pelvic inlet, and finally the uretrovesical junction, right? That is PUJ, then pelvic inlet and UBJ. That's very simple. That completes the renal anatomy, and now we will begin with the most important topic, that is the renal physiology. So the first topic is the fluid compartment. So our body is made up of water, and the 60% of the body mass is water, that is called as the total body water, right? Then the total body water is further divided into two compartments, that is the intracellular fluid and the extracellular fluid. The intracellular fluid is approximately 40%, while the extracellular fluid is 20%. So that is the 60-40-20 rule, right? The intracellular compartment is mainly composed of potassium, magnesium, organic phosphates like ATP, while the extracellular compartment is predominantly composed of sodium and chloride. This question was asked this year, that what is the main or the major constituent of the intracellular compartment, and the answer was potassium, right? The other components of extracellular compartment are bicarbonate and proteins like albumin. Now, the extracellular fluid is composed further of the interstitial fluid, as well as the blood volume, right? And the blood volume is composed of the RBC volume and the plasma. The RBC volume is calculated by calculating the hematocrit, right? And the normal hematocrit is 45%. For measurement of plasma volume, radio-labeled albumin is used, while for extracellular fluid, mannitol and inulin are used to measure its volume, right? For total body water, you can use tritium or deuterium, and the intracellular volume is not calculated directly. It is calculated by subtracting total body water and the extracellular volume, right? Now coming to serum osmolarity, it is approximately 275 to 295 milliosmoles per kg water, while the plasma volume is calculated by multiplying the total blood volume by 1 minus hematocrit, right? Next we will talk about the glomerular filtration barrier, which is very important. So what it does is that it is responsible for the filtration of plasma, and it depends upon two things. First is the charge criteria, and second is the size criteria. Therefore it is called that it is size and charge selective, right? What is first of all, it is composed of three parts. First is the fenestrated capillary endothelium. Here we can see there are slits in the capillary endothelium or pores, that is called as the fenestrated endothelium. Next is the basement membrane of the glomerulus, right? This is the GBM. The basement membrane is composed of collagen type 4, right? And it also contains heparin sulfate, which is nothing but it is a mucopolysaccharide that provides the negative charge to the glomerular basement membrane. This question was also asked. This becomes important because this is a direct correlation between an integration between biochemistry and the renal physiology, right? So the charge barrier is due to heparin sulfate, right? And this prevents the entry of negatively charged molecules like albumin. So albumin is small in size, but due to being negatively charged, it is not filtered freely by the basement membrane. Third is the foot process or the visceral epithelial layer. So the three parts of the filtration barrier are the endothelial layer, glomerular basement membrane, and the foot process or the visceral epithelial layer, right? We talked about the charge barrier. The size barrier, it is due to the fenestrated capillary endothelium here, and it prevents the entry of molecules which are more than 100 nanometer in size. Also, it is due to the slit diaphragm, which is nothing but the interposition of the podocyte with the glomerular basement membrane, right? And it is a special channel in the podocyte. It prevents the entry of molecules which are more than 4 to 5 nanometer in size. So the endothelial layer will prevent the entry of molecules which are more than 100 nanometer, while the slit diaphragm prevents the filtration of molecules which are more than 4 to 5 nanometer in size. This is very important. Next, we talk about the renal clearance. So for renal clearance, the formula is C of a substance is its concentration in the urine divided by concentration in plasma multiplied by the urine flow, right? So urine flow, it would be in ml per minute. This will be in mg per ml. Therefore, the unit of clearance comes out to be ml per minute, right, as these two will cancel out. So this is an important equation, and they can give you direct MCQs based, they can give you numericals based on this simple equation. So what happens is that if the clearance is less than GFR, the substance would be reabsorbed, right, or it is not freely filtered, while if the clearance is more than GFR, then the substance is said to be secreted. For substances that have clearance equal to GFR, there would be no net reabsorption or net secretion, as in the case of inulin, which is the closest indicator of the GFR, right. So talking about GFR, it stands for glomerular filtration rate, and as we talked, the clearance of inulin is approximately equal to the GFR because it is neither absorbed nor secreted. The normal GFR is 100 ml per minute. Also remember that creatinine clearance overestimates the GFR. That means it would be more, like around 120, right, when in actual it would be only 100 ml per minute. Why this happens is because creatinine is moderately secreted by the renal tubules. So now look at this graph. This is the plasma creatinine on the y-axis, while glomerular filtration rate on the x-axis, right. So you can see as the GFR increases, the plasma creatinine value decreases. What this means is that this graph is showing nothing but a normal function of the kidney, that is, in cases of low GFR, right, for example 25, the plasma creatinine would be 4. Low GFR means increased plasma creatinine, right, and this is the marker that we use in our wards as well to estimate the function of the kidneys. And as the value of the GFR increases, that is, it reaches a value of 125, the creatinine reaches a value less than 1, right. So creatinine is used for the estimation of GFR. Next is effective renal plasma flow, right. So it is estimated by using para-aminohippuric acid. Why? It is because it is nearly 100% excreted by the kidney. For renal plasma flow, again we use the same formula, the clearance of pH. To calculate the renal blood flow, right, we use the formula renal plasma flow upon 1 minus hematocrit, and the renal blood flow is usually 20 to 25% of the cardiac output, and this remains constant because kidney has an auto-regulatory mechanism. eGFR slightly underestimates the renal plasma flow because the the pH is 99.99% secreted by the kidneys, right, that's why. So remember, inulin clearance is GFR, which overestimates the GFR, and this is the graph between plasma creatinine and the GFR, which is very useful in wards, right, that the GFR decrease would lead to an increase in plasma creatinine, while the effective renal plasma flow would be estimated by the clearance of para-aminohippuric acid, and it slightly underestimates the true renal plasma flow. Next, talking about filtration. So, filtration fraction, it is given by the formula GFR by RPF, that is glomerular filtration rate upon the renal plasma flow, and a normal filtration fraction is approximately 20%. Filtered load is mg per minute. It is given by the equation GFR into plasma concentration of that substance. Now what happens is that we already saw that the afferent arteriole and efferent arteriole are responsible for the pushing forward or the filtration of the substances through the glomerulus. So, if you see that the dilation of afferent arteriole, right, and the constriction of efferent arteriole leads to increase in a GFR. Remember this first case. And second, dilation of any arteriole would lead to increase in blood flow, that is the renal blood flow, while constriction leads to a decrease in renal blood flow. Right. So, let us take all the cases. GFR, renal plasma flow, and filtration fraction, which is nothing but a ratio of the two. So, when the afferent arteriole constricts, right, we remember that dilation leads to increase in GFR. So, constriction would lead to a decrease in GFR. Constriction always leads to a decrease in renal plasma flow, but the filtration fraction would be constant because the ratio is not affected. Next is afferent arteriole dilatation. In that case, the GFR will increase, renal plasma flow will increase, but again the filtration fraction is normal. Now, in case of efferent arteriole constriction, what happens is that the GFR increases, the renal plasma flow will decrease because there is constriction, and the filtration fraction, what will happen, that it is increasing because the numerator is increasing while the denominator is decreasing. Right. Now, if there is increase in plasma protein, so what does plasma protein does is that it increases the oncotic pressure of the glomerulus. So, if the plasma protein increases, then what happens is that the flow will be in the opposite direction, that is the GFR will decrease, right. So, the GFR decreases, there will be no effect on the renal blood flow, and due to the decrease in GFR, the filtration fraction will again decrease. Opposite, if there is a decrease in plasma proteins, that is a decrease in the oncotic pressure, the GFR will increase, again no change on the renal plasma flow, and the filtration fraction will increase. If the ureter is constricted, right, so naturally what will happen, the GFR will decrease, there is no effect on the plasma flow, and due to this the filtration load is decreased. And in case condition causing dehydration like burns and loss of third fluid space, again there is decreased volume. So, naturally GFR will decrease. Here there will be a greater decline in the renal plasma flow due to decline in the body volume, and due to this, since the decline in renal plasma flow is more than the GFR, the filtration fraction will increase, right, because the denominator is decreasing more than the numerator. So, these are the conditions, and this is the table that is given, which is very easy if you learn the concepts, right. These are important. We missed one condition, let us also discuss that. In case of efferent arteriole dilatation, what will happen, the GFR will decrease, but the renal plasma flow will increase. So, this will lead to a decrease in the filtration fraction again, right. Now, the prostaglandins, what they do is that they cause dilation of the afferent arteriole, thereby increasing the GFR. So, if we give NSAIDs to the patient, there would be a decrease in the prostaglandin causing a decrease in dilatation, and therefore the NSAIDs are responsible for decreasing the GFR, right. Similarly, angiotensin II, what it does is that it constricts the efferent arteriole, but if we give ACE inhibitors, it will lead to a decrease in constriction of the efferent arteriole, again decreasing the GFR, right. Let us look at this table. NSAIDs causes afferent arterial constriction, right? It will decrease the GFR, and the ACE inhibitors will cause efferent arteriolar dilatation, again decreasing the GFR. The difference is that the renal plasma flow will be decreased in case of NSAIDs, while the renal plasma flow is increased with ACE inhibitors, right? Also remember this equation, which is very basic, that the net filtration fraction, it is given by this formula. So the hydrostatic pressure of the glomerulus will lead to a net filtration, right, while the hydrostatic pressure of Bowman's space would lead to a net decrease in the filtration. Similarly, the oncotic pressure of the glomerular capillaries would lead to a decrease in the filtration, while the oncotic pressure of the Bowman space would lead to an increase in filtration. Okay. Why? Because the oncotic pressure would mean that there is increase in the concentration and it would attract the fluid. So the net direction would be this. So if you talk about the net filtration pressure, right, it will be all the arrows towards this side are added and this side are subtracted. Okay. So this is PGC. Wait, let me remove this. Right. So the net pressure would be PGC plus pi BS minus PBS plus pi GC. Okay. So the net would be hydrostatic pressure of glomerulus plus oncotic pressure of Bowman minus hydrostatic pressure of Bowman's plus oncotic pressure of the glomerulus. Now, how do you calculate the reabsorbed and secreted substances, right? So reabsorption takes place in the PCT as well as secretion. The substances that are reabsorbed goes to the peritubular capillary, and the substance that needs to be secreted are secreted by the peritubular capillaries. Okay? So this takes place between the PCT and the peritubular capillaries. Excretion, which is given by the formula, the concentration is in urine multiplied by the urine flow, very easy. Then for reabsorption, it is filtered minus excreted. Okay, so filtered load minus the excreted load, while secretion would be excreted minus the filtered load, right? FeNA, it is what? It is the fraction excretion of sodium, and it is very helpful in differentiating the pre-renal and post-renal causes of AKI, which we'll do. But here we can see how it is calculated. It is calculated by the sodium excreted divided by sodium filtered, right? That is the fractional excretion of sodium. And putting in the formula, excretion is V into U sodium divided by GFR into plasma concentration of sodium. Now we know GFR is U creatinine, urinary concentration of creatinine upon plasma creatinine multiplied by V. So we put this value here, and the equation comes out to be V into UNA upon PNA upon U creatinine into V divided by P creatinine. Okay, we will cut. So finally we have FeNA as P creatinine upon U creatinine multiplied by U sodium upon P sodium. Right, that's very easy. Another way to calculate the fractional excretion of sodium. So why this is important is that because they are asking formula based questions in the recent exams, right? In one exam they had asked about I think sodium deficit or the something like that, and in another they asked about the formula for calculating the GFR in a newborn child, right? So therefore these numericals also become important as the trend is changing and shifting towards these kind of examples. Next we'll talk about the clearance of glucose. So glucose, this is very important, and numericals based on this is asked as well. So what happens is that glucose at normal plasma level, it ranges between 60 to 120 milligram per deciliter, right? And if the range is if the concentration is between this range, glucose is completely reabsorbed, that is 100% reabsorbed in the PCT by the sodium glucose co-transport. Or the SGLT2. If the glucose reaches a value more than 200 milligram per deciliter, that is the cutoff value for diabetes, then the glucose starts appearing in the urine. So here we can see between 0 to 200, glucose is 100% absorbed, and 200 is called as the renal threshold, because beyond which it is excreted and it appears in the urine in the form of glycosuria. Now what happened is that if the glucose transport reaches more than 375 milligram per minute, right, this is called as transport maxima, right. So at this rate, what happens is that all the transporters of the glucose are fully saturated. So this is the Tm. Now if you see that the Tm for glucose is reached gradually, right. Why this happens is because of heterogeneity of the nephron. That is, it means that Tm is different at different points. Therefore, there is this splay in reaching of the saturation, right. And this is called as the splay phenomena. In normal pregnancy, we read that there is an increase in GFR, right. This will lead to increase in filtration of all the substances, including the glucose. So the filtration of glucose increases in pregnancy. So the glucose threshold occurs at a lower plasma glucose concentration. So suppose the glucose threshold might occur here before the plasma threshold, and therefore the glucose may start appearing in the urine at values less than 200 milligrams per deciliter, which is normal glycosuria in pregnancy. So after this, let's look at the nephron transport physiology for each segment of the glomerulus, starting with the proximal convoluted tubule, right. So the basolateral membrane is that is closest to a blood vessel, while the apical membrane, the epithelium of the PCT is brush border, right. And here mainly the reabsorptions take place. So what it does, that it is responsible for the 100% reabsorption of glucose and amino acids, right, along with the maximum absorption of bicarbonate, sodium, chloride, phosphate, as well as water. So here the contents are isotonic. Also it generates and secretes ammonia, right, and it helps in kidney to produce more H+ ions. Let us look at some hormonal influences. So first we have the parathyroid hormone. So parathyroid hormone, what it does is that it inhibits the sodium phosphate co-transport, leading to increased phosphate secretion, right. We know that parathyroid is responsible for increasing the phosphate excretion. Next is angiotensin II. So angiotensin II, what it does is that it stimulates the sodium hydrogen exchanger. So what will happen is that there would be increased sodium reabsorption. Due to increase in sodium reabsorption, there would be an automatic increase in bicarbonate and an increase in water reabsorption, because water follows sodium and there is a sodium bicarbonate co-transport present. So basically what it does is that it causes contraction alkalosis. Next is the thin descending loop. right? So here what happens is that there is passive reabsorption of water due to medullary hypertonicity, right? And remember that the thin loop of Henle, it is impermeable to sodium. This is also known as the concentrating segment, because here what happens is that the urine becomes hypertonic naturally, because water is being reabsorbed and the contents become hypertonic. In PCT it was hypotonic, isotonic. The next is a thin ascending, the next would be the thick ascending loop. Here what happens is that there is reabsorption of the sodium potassium chloride due to the presence of sodium potassium 2 chloride pump, right? And also it causes the paracellular reabsorption of magnesium and calcium, right? This is possible due to the lumen potential, right, which is generated by the backleak of the potassium ions. So here around 10 to 20% of the sodium is reabsorbed. Also, the basolateral membrane has the presence of a sodium potassium ATP pump that is responsible for the backleak of the potassium ions. Next we will talk about the distal convoluted tubule. So here there is reabsorption of sodium and chloride due to the sodium chloride channel, and this segment is impermeable to water. So here what happens is that there is dilution of the urine and the urine becomes hypotonic. Also, PTH has receptors on the basolateral membrane of the DCT, and what it does is that it stimulates the sodium calcium exchanger, increasing calcium reabsorption. So, on PCT, the parathyroid hormone is responsible for the phosphate excretion, while in DCT it causes the increase in calcium reabsorption. The net effect of parathyroid hormone is therefore increase in calcium and decrease in phosphate. Right, this is very important. In DCT, around 5 to 10% of sodium is reabsorbed. Right. Also remember, the thiazide diuretics acts on the DCT by inhibiting the sodium chloride channel, while the loop diuretics, as the name suggests, would act on the loop of Henle in the thick ascending limb, and it inhibits the sodium potassium 2 chloride channels. Fine. Now, the last segment is the collecting duct. It has three types of cells: the principal cell, alpha intercalated, and the beta intercalated cells. So what happens is that in the principal cell there is ADH receptor, that is the V2 receptor on the basolateral membrane. So what it does is that in the presence of antidiuretic hormone, it increases the expression of aquaporin channels on the apical membrane and increases the water reabsorption, that is, it prevents the diuresis, right? Also, there is a presence of sodium potassium pump in the presence of aldosterone, which has a receptor again on the basolateral membrane. It activates the sodium potassium pump, leading to increased reabsorption of sodium and increased excretion of potassium, right? So the net effect is that it increases sodium while it decreases the potassium. Also, aldosterone has receptors on the alpha intercalated cell, where what it does is that it increases the secretion of hydrogen, right? So the aldosterone is responsible for sodium retention while loss of potassium and hydrogen. Aldosterone also increases the activity of the ENaC channel, hence increasing the sodium concentration, right? So the drugs acting on the ENaC channel and inhibiting it are amiloride and triamterene, while spironolactone and eplerenone are the drugs acting on the mineralocorticoid receptor on which the aldosterone acts, right? Therefore, in the presence of or due to spironolactone, what happens is that there is no potassium excretion, hence it is known as potassium sparing diuretic. Next, we will be studying the renal tubular defects, right, which is a very common and a frequently asked question. It's very important. And we'll be studying about the Fanconi syndrome, right, that affects the PCT, then the Bartter syndrome affecting the loop of Henle, the ascending loop, Gitelman syndrome affecting the DCT, and finally the Liddle syndrome and same, that is affecting the collecting duct. So let us start looking at these symptoms or at these defects one by one. Right. So in Fanconi syndrome, what happens is that there is a generalized defect in the reabsorption in the PCT. So due to this, there is an increase in excretion of amino acids, glucose, along with bicarbonates and phosphate. Right. Due to this loss of bicarbonate, there will be metabolic acidosis. And this is what is the proximal or the type 2 RTA. Along with hypophosphatemia and hypokalemia. Right. It is caused due to hereditary defects like Wilson's disease, then glycogen storage diseases, tyrosinemia. It is also associated with multiple myeloma and use of nephrotoxic drugs like isophosphamide and cisplatin, both of which are anti-cancer drugs, right. Also, lead poisoning can also be a cause. So we read that due to bicarbonate loss there is metabolic acidosis, while due to phosphate loss what happens is that it can lead to hypophosphatemic rickets causing growth retardation. Also volume depletion is commonly seen here, right. This is Fanconi syndrome. Next is Bartter syndrome. Here what happens is that there is a reabsorption defect in the loop of Henle, right. We remember the loop of Henle has the sodium potassium 2 chloride channel, right. So what happens in Bartter syndrome, there is defect of the sodium potassium 2 chloride channel. It is an autosomal recessive disorder and there is metabolic alkalosis along with hypokalemia and hypercalciuria, right, and it mimics the chronic use of loop diuretics because they have the same location. So this is Bartter. Also remember that Barton gene is located in the cochlea, right. So in Bartter syndrome there may also be sensory neural hearing loss. Then next is Gitelman syndrome. It is due to the reabsorption defect of NaCl in the DCT due to the hampering of the sodium chloride channel. Again there will be metabolic alkalosis along with hypomagnesemia because there was paracellular transport of magnesium and calcium, right. Hypokalemia again, but there is no calcium in the urine. That is a very important difference between Bartter and the Gitelman syndrome, right, and it mimics the chronic use of thiazide diuretics. This was loop diuretics. So very important to note is that calciuria is seen in Bartter syndrome while it is not seen with Gitelman syndrome. Therefore stones would be also associated with Bartter syndrome while stones are usually not seen in the Gitelman syndrome. Gitelman syndrome is also autosomal recessive. Next is Liddle syndrome. So here there is a gain of function mutation of the ENaC sodium channels which is present in the collecting duct. Due to this what happens is that there is increased sodium reabsorption, right. Again there will be metabolic alkalosis, then potassium loss leading to hypokalemia, hypertension. Why? Because sodium is increased and it is usually called as hypokalemic hypoaldosteronic hypertension. Why? Because the aldosterone is low and the potassium is also low. it is an autosomal dominant disorder, very important, right? Because Bartter and Gittleman were all autosomal recessive disorders. For treatment, we need inhibitors of ENaC channel, that is amiloride, right? We read in the collecting duct that amiloride is an inhibitor of the ENaC channel. Next is SAME, which stands for Syndrome of Apparent Mineralocorticoid Excess. It is due to the deficiency of 11 beta HSD, which is responsible for the conversion of cortisol to cortisone, right? So what happens is that due to increase in cortisol, there is increased activation of the mineralocorticoid receptors. This will again cause metabolic alkalosis, hypokalemia, hypertension, but with a decreased serum aldosterone, right? There is activation of the mineralocorticoid receptor in the absence of aldosterone. Hence, this is also an example of hypokalemic hypoaldosteronic hypertension, right? As the name suggests, there is apparent mineralocorticoid excess. In actual, there is not excess of mineralocorticoid, just the expression of or the activation of the mineralocorticoid receptors. SAME is also an autosomal recessive disorder, and it can also be due to consumption of licorice that contains glycyrrhetinic acid that blocks the activity of the 11 beta HSD or 11 beta hydroxysteroid dehydrogenase. For management, potassium sparing diuretics are given, right? Because it will decrease the mineralocorticoid effect, like spironolactone or eplerenone, or corticosteroids can be given because the exogenous steroids will cause negative feedback, decreasing the mineralocorticoid receptor activation. Here let us look at some renal disorders, since we have already covered Bartle, Gittleman, Liddle and SAME. So it is given on page 615 of the 21st edition, or after electrolyte disturbances. You can see it in the, so we will look at the conditions one by one, right? First is SIADH, which is syndrome of inappropriate secretion of ADH, right? So basically it is due to increase in ADH, or there is increase in antidiuretic hormone. So due to this, what will happen is that here the BP is usually normal, or it might be slightly increased. So here what happens is that there is increased water reabsorption, and this leads to dilutional hyponatremia, which is also called as euvolumic hyponatremia, right? So here the BP would be normal, or it might be slightly increased due to increase in volume. The plasma renin decreases. Why? Because of increase in volume. Due to decrease in renin, the aldosterone will decrease, while there is no effect on serum magnesium and serum calcium. In cases of primary hyperaldosteronism, right, that is, there is increase in aldosterone, right? So obviously aldosterone is increased. Due to increase in aldosterone, there will be a negative feedback on the plasma renin, which decreases. But due to aldosterone, the blood pressure increases. Why? We already studied that the aldosterone is causing sodium retention that leads to increase in the blood pressure. Again, there is no effect on magnesium and calcium. Renin secreting tumors of kidney would lead to increase in the plasma renin secretion, thereby increasing the aldosterone levels, while there would be again causing an increase in the blood pressure, while no effect would be seen in the serum magnesium and calcium levels. In Bartter syndrome, what happens is that there is a diuretic effect because it mimics a loop diuretic, right? So due to the decrease in volume, there would be activation of plasma renin and aldosterone, and they will maintain the BP. That is, due to the diuretic action, there would be a decrease in volume, causing a decrease in blood pressure, but due to the activation of renin angiotensin aldosterone system, there would be a decrease in volume, leading to a decrease in BP, right? So BP here is normalized. There is no effect on serum magnesium, while urine calcium would increase, that is there will be hypercalciuria. In Gentleman syndrome again, since it acts as a thiazide diuretic, right, the actions would be same, that is increase renin and aldosterone with normal blood pressure. The serum magnesium and calcium will decrease and the urine calcium will also decrease. So this is very important to differentiate between the Bartter and the Gentleman syndrome. Next is the Liddle syndrome. Here what happens is that due to activation of ENaC channels, the blood pressure increases, and the increased blood pressure leads to a decrease in the plasma renin, causing a decrease in the aldosterone, while there is no effect on the serum calcium and magnesium level, right. So here there is hypoaldosteronemic hypertension in Liddle as well as same. So you understand the difference, that in conditions like primary hyperaldosteronism, there was increase in aldosterone which was causing increase in BP, while in Liddle and same, what happens is that the increase in BP is causing a decrease in the aldosterone levels. We will come back to it later and we will discuss it again when we do the renal angiotensin system again. Now let us move to the next topic, which is the relative concentration along the PCT, right. So this is the PCT and the graph here is again important graph, because what they can do is that they can hide all these things and they can ask like what is this and so on. Okay. So let's see how to go about doing this graph. Yeah, so this is PCT and the graph is showing the relative concentration of some substances. So first let us start with this line, right. So here the y-axis is showing tubular fluid divided by plasma ratio, that is why you can see ratios, and along the x-axis we can see the length of the PCT, right. So this would be mentioned or labeled in the graph for you to figure out what is being asked. So when this fraction, that is TF by P or tubular fluid by plasma ratio is 1, that means that the solute and water are reabsorbed at the same time, or the solute is reabsorbed just like the water. So basically it is comparing all the solute concentration as that of water. Okay. So we can see that the potassium and sodium are closely having TF by P approximately to 1, and chloride will have a slightly greater TF by P, right. So if TF by P is more than 1, it means that the solute is being secreted, like PAH is maximally secreted 100%. So it will have the maximum pH, right. Creatinine and inulin will have TP by F slightly lesser than pH but still in a greater range, while urea would be having the ratio more than 1 but less than both pH, creatinine and inulin, right. Now for the substances that have TF by P less than 1, what it means is that the solute is being reabsorbed more, right, as compared to that of water. So these are those that are reabsorbed more. The examples are bicarbonates, amino acid and glucose. So remember, glucose and amino acid are 100% reabsorbed in the PCT. So definitely they have TF by P less than 1, and the ion that is having or that is being reabsorbed is bicarbonate. Now this is our favorite topic, the renal angiotensin aldosterone system. So let us look at it. So what happens is that the RAAS is getting activated by some factors which are either a decrease in BP, decreased sodium chloride delivery and increased sympathetic tone. So decreased BP is sensed by the baroreceptors, a decrease in sodium chloride is sensed by macula densa, and increased sympathetic tone is sensed by the beta 1 receptors. In any of these conditions, there is activation of RAAS, right. So what happens is that the juxtaglomerular apparatus secretes renin, Renin causes the conversion of angiotensinogen to angiotensin 1. Angiotensinogen is secreted from the liver. Now angiotensinogen 1 is converted to angiotensinogen 2 by ACE, right, that is secreted from the lungs. ACE stands for angiotensinogen converting enzyme, right. It has another function that it causes the breakdown of bradykinin. The actions of angiotensinogen 2 are, it first causes vasoconstriction, thereby increasing the BP. Second, what it does is that it constricts the efferent arteriole and it preserves the GFR. Third, it increases the sodium hydrogen pump activity on the PCD cells, leading to contraction alkalosis, which we read. It also leads to the secretion of aldosterone that acts on alpha intercalated cells to increase the H plus excretion and on the principal cells to increase the sodium reabsorption and increase potassium excretion, right, by acting on the sodium potassium ATPase and the ENaC channels. Also what it does is that it causes water reabsorption by increasing the expression of aquaporins on the apical membrane. This we have all read. Also it acts on the hypothalamus, especially on the thirst centers, and increases the thirst, right, because by drinking more water we only increase the blood volume and restore the blood pressure and the GFR. Also it acts on pituitary and it stimulates the secretion of antidiuretic hormone, which will again increase the water reabsorption. So this is basically the RAAS. Now here only let us see the juxtaglomerular apparatus. It consists of mesangial cells, then the juxtaglomerular cells, which are nothing but the modified smooth muscles of the afferent arteriole. This is important, right? Next we have the macula densa cell, which are the sodium chloride sensors situated in the DCT. So the juxtaglomerular cells are responsible for the secretion of renin in response to decreased BP, decreased sodium chloride delivery and increased sympathetic tone. So basically juxtaglomerular apparatus is the one that is responsible for maintaining the GFR via the RAAS. Since beta 1 receptors are present in the the juxtaglomerular apparatus, so in conditions where there is increase in blood pressure, we can give beta 1 blockers, right, or the beta blockers that will lead to suppression of JGA, leading to decrease in renin production, decrease angiotensin 2 and decrease aldosterone, causing a decrease in blood pressure. Next are kidney hormones. So kidney secretes some hormones which we will study, the first being erythropoietin, right. It is released by the interstitial cells in the peritubular capillaries, right. We already studied it is secreted in response to hypoxia, where there is increased hypoxia inducible factor leading to increased erythropoietin secretion. So what it does is that it stimulates the RBC proliferation in the bone marrow, and it is given in patients who are suffering from anemia, especially due to chronic kidney diseases. Next is calciferol, which is vitamin D. So what happens is that in PCT there is conversion of 25 hydroxy vitamin D to 125 hydroxy vitamin D3, that is known as calcitriol, or that is the active form. Vitamin D is responsible for increasing both the calcium and phosphate absorption, in contrast to the parathyroid hormone, which causes increase in calcium absorption while increase in phosphate excretion. Also another important point to note is that the conversion of 25 hydroxy to 125 hydroxy D3 is by 1 alpha hydroxylase, right, and 1 alpha hydroxylase is stimulated by parathyroid hormone. So basically parathyroid hormone is responsible for the activation of vitamin D3. Next are the prostaglandins. So prostaglandins So prostaglandins are paracrine secretion, right? And we again have already studied that it is responsible for vasodilation of the afferent arteriole, right? And prostaglandin inhibitors like NSAIDs would lead to constriction of the afferent arteriole and decreasing the GFR. Next is dopamine, which is secreted by the PCT, and it is responsible for natriuresis. At low doses, that is between 2 to 10 microgram per deciliter, it is responsible for increasing renal blood flow by dilating the interlobular arteries, right? While at high doses, it causes vasoconstriction. Therefore, this question was asked last year, that at what dose of dopamine can be used in patients with oliguric cardiac failure. Atrial natriuretic peptide, or the ANP, right? It is secreted in response to increase in atrial pressures. So what it does is that it causes an increase in GFR and increase in sodium filtration, as the name suggests. So the net effect is it causes a decrease in sodium and thereby a decrease in water, right? Natriuresis. Next is angiotensin 2. We already know that it is secreted in response to decreased BP by the RAAS, and it causes the constriction of the efferent arteriole. Due to this, what happens is that the GFR and filtration fraction increases, leading to an increase in sodium reabsorption in the proximal and the distal nephron. So what is the net effect is that it causes increase in filtration fraction, especially in the low volume states, along with increase in sodium reabsorption. The next hormone is parathyroid hormone, which is secreted in response to decrease in plasma calcium or an increase in plasma phosphate or a decrease in 125 calcitriol. So the actions of parathyroid hormone, as already discussed, are increase in calcium, decrease in phosphate and increase in vitamin D3. Right. Next we have the aldosterone and the ADH. So aldosterone is again secreted in response to a low blood volume, and it acts via the RAAS system, right? And it leads to increase in sodium reabsorption and decrease in potassium, or increase in potassium excretion, as well as hydrogen excretion, right? So it causes sodium water absorption with loss of potassium and hydrogen. Next is the ADH, which is also called as the vasopressin, secreted in response to the increased plasma osmolarity, right, or a decrease in blood volume. So what it does is that it binds to the principal cells and increase the number of aquaporin receptors, which will lead to increased water absorption. These are all repeat points. Also what it does is that it causes an increased reabsorption of urea to maintain the corticopapillary osmotic gradient. Also, one more thing need to remember is that the osmolarity of urine, it is isotonic in the PCT, hypertonic in the loop of Henle. That is why it is also called as the concentrating segment. Then hypotonic in the DCT, and again hypertonic in the collecting duct. Next we will talk about electrolyte disturbances in the body, right? So first is potassium, and we are talking about potassium shifts. So first are condition causing intracellular potassium shift, and this leads to hypokalemia, that is less potassium is available in the blood, and second is the extracellular potassium shift leading to hyperkalemia. The causes of intracellular, and this question was asked this year only. So first cause is hypoosmolarity, then alkalosis, beta agonist, and this was the question that was asked. The option in the exam was, I think, SABA, maybe, or something beta agonist, right? Then insulin. So the beta agonist and insulin, what they do is that they increase the sodium potassium ATPase, right? Another way to remember is that insulin pushes the sodium inside the cell. So these are all the causes of hypokalemia. Then extracellular potassium shift or hyperkalemia can be caused by digoxin. Why? Because it blocks the sodium potassium ATPase channel. Hyperosmolarity, right, or lysis of a cell. For example, in rhabdomyolysis or tumor lysis syndrome. This is again an exam question. In both these cases, what happens is that there is lysis of cell, which is very obvious, would lead to increase in potassium in the blood or an extracellular shift. Then acidosis, beta blockers, right, all the opposite conditions. High blood sugar, because it will lead to insulin deficiency. Succinylcholine, increased risk in burn and in muscle trauma, right? Therefore, this is a important question, PYQ, that succinylcholine is contraindicated in burns patient and trauma patient, right? This we will study in anesthesia also. Now talking about the ECG changes, so in hypokalemia we can see U waves, right, flattening of T waves. Apart from that, there can be arrhythmia, muscle cramps and weakness, while hyperkalemia is responsible for wide QRS and peaked T waves along with arrhythmias and muscle weakness. This is very important. Even ECGs have been asked whether it is hyperkalemia or hypokalemia. So they are very important. So let us here look at some important tables of electrolyte disturbances. So first is hypertension with decreased potassium, right? We've already done some of the causes, we'll just revising it here itself. So first is causes with increased renin and increased aldosterone. So they are called as secondary hyperaldosteronism, and the causes are renovascular hypertension or malignant hypertension and reninoma, right? Then second, we have causes of that have an increase in aldosterone, but there is a decrease in renin due to negative feedback of increase in aldosterone on renin. These are called as primary hyperaldosteronism, and the causes of primary hyperaldosteronism are Conn's disease, bilateral adrenal hyperplasia and glucocorticoid responsive aldosteronism, right? Finally, which is very important, is low renin, low aldosteronic hypertension, right, that I was telling since a long time, that is hyporeninemic, hypoaldosteronemic, hypokalemic hypertension, right? These conditions, they have features of hyperaldosteronism without actual increase in the aldosterone levels. So here what happens is that there can either be an increase in cortisol, which can stimulate the mineralocorticoid receptors, or the cortisol can be normal. So first, if the cortisol is normal, then the cause is due to an increased expression of ENaC channel, and the diagnosis is nothing but a Liddle syndrome, while causes of hypercortisolism are Cushing's, same, right, which we read was a deficiency of 11 beta HSD causing an increase in cortisol level, and licorice, which again causes a deficiency of 11 beta HSD. So this table is very important, and especially the most important part to know is or are the causes of hyporeninemic, hypoaldosteronic hypertension, right, with a decrease in potassium levels. So cortisol levels high are Cushing's, same licorice, while Liddle's is with a normal cortisol level. So if you know this table, and you don't need to remember it, it's just a common understanding, but if you remember this or have a picture of this table in your mind, a lot of questions of endocrine can be easily solved, and it forms a very important part of the endocrine system. Next electrolyte deficiency is sodium. So first we'll talk about low hyponatremia or low serum osmolarity of sodium, right. It is again of three types: hypovolumic hyponatremia, euvolumic hyponatremia, and hypervolumic hyponatremia. So euvolumic hyponatremia we already know is SIADH, right. Here what happens is that the total body water is increased but the total body salt is normal. So this is nothing but this is dilutional hyponatremia. So again here we can divide them into two causes. First, when the urine osmolarity is less, and second, when the urine osmolarity is more than 300 milliosmoles per kg. So first, if the urine osmolarity is more than 300, then the causes are simple. First is the most common cause, that is SIADH. Other causes are hypothyroidism and hypercortisolism. But remember SIADH here. Second, if the urine osmolarity is low, it means that it could be a psychogenic cause, that is the patient is drinking a lot of water causing a dilutional hyponatremia, or in cases of endurance and beer potomania, right. Again beer causes dilutional hyponatremia. Hyponatremia due to beer is called as beer potomania, right. Next we have hypovolumic hyponatremia. Here again we see the urine sodium which is less than 20 or more than 20, right. So if the urine sodium is less, then the causes are either diarrhea, vomiting, burns and dehydration, right. Third place, fluid loss. If the urine sodium is more, that means that there is increased urine excretion of sodium that is leading to hyponatremia. So this is a classical case of cerebral salt wasting, where what happens is that there is increased secretion of brain natriuretic peptide leading to increased excretion of sodium. Other causes can be diuretic administration or Addison's disease, right. But the most important cause that you need to remember in hypovolumic is cerebral salt wasting, while in euvolumic is SIADH. Finally, we have hypervolumic hypernatremia. Here what happens is that there is increase in total body water as well as total body salt, but the increase of total body water is more than the total body salt, leading to again hyponatremia. Here we'll again see whether there is excretion of sodium in the urine. If it is if the urine is more than 20, it means that it is due to a kidney disorder, that is AKI and CKD, while if it is less than 20, it means that it is a non-renal disorder like cirrhosis, CHF. So this table is very important and you can revise this table, add it to your 20th notebook as well for quick revision of causes of hyponatremia, right. Then next we have hypernatremia. Hypernatremia, again we have divided with urine osmolarity more than 800 but volume less than 500 milligram per deciliter. So it can be due to extrarenal loss, GI loss and insensible loss of water, leading to increased salt concentration. Next we have increase in urine osmolarity more with volume also more than 500 milligram per deciliter. This is a classical example of osmotic diuresis, right. Finally, if the urine osmolarity is less but the volume is more than 500 milligram per deciliter, it indicates that it is due to diabetes insipidus, right. So for diabetes insipidus we see whether it is a central diabetes insipidus or a nephrogenic diabetes insipidus, right? So what we do is that we give desmopressin to the patient, and if it is responsive to desmopressin, then it means that it is a central DI, while if there is no response to desmopressin, this means that there is a defect in the desmopressin receptor or the ADH receptor which is present in the kidney, then that is a case of nephrogenic diabetes insipidus. ठीक है, तो you have to remember is that for hypernatremia, check whether the serum osmolarity is less than 800, right, and the volume is more than 500. Then you can or you can think of the diagnosis of diabetes insipidus, right. So let us look at all these differentials of sodium disturbances. So first we have cerebral salt wasting. We know there is increased secretion of BNP, which leads to a decrease in sodium by natriuresis. Also there is polyuria and hypovolumic hyponatremia. SIDH is again syndrome of inappropriate secretion of ADH, where there is euvolumic hyponatremia, right. One point that you can remember is that ADH is directly proportional to uric acid secretion. So in SIDH what happens is that there will be increased uric acid secretion leading to hypouricemia, right. This is just to remember. Now next are some important causes of SIADH. First are paraneoplastic conditions like small cell cancer of lung and thymoma leads to SIADH, right. Then in pneumonia, then some drugs like SSRI, clopramide. This is very important. The drugs are very important, and it has been asked in previous year questions that what drug causes SIADH. So SSRIs, clopropamide, carbamazepine, vincristine, cyclophosphamide, and MDMA or ecstasy, right, or Molly. Then next is diabetes insipidus, which is very different from the two conditions because in cerebral salt wasting and SIADH there is hyponatremia, while in diabetes insipidus there is hypernatremia with polyuria and hypovolemia, right. So this is again another table to quickly look at the important conditions of sodium disturbance, right. After sodium, let us move to calcium. So if there is low serum calcium, there can be tetany, seizures and increased QT interval. Two important signs of hypocalcemia or tetany are Schwarzschild sign, which is the twitching of facial muscles, and the HorseShoe sign, which is the carpopedal spasm. Hypercalcemia is associated with stones, bones, groans, psychiatric overtones, right. That is renal stones, bone pain, abdominal pain, then anxiety, altered mental status, and one more point, thrones, which is increased urinary frequency. Next, magnesium. Again, hypomagnesemia can lead to tetany. Then torsade de pointes, which is the twisting of the points, right. We'll read about this in the cardiac unit. Then it can lead to hypokalemia, hypocalcemia, especially when magnesium is less than 1 milli equivalent per deciliter, right. So we might have seen that sometimes there are some unknown causes of hypokalemia, so we should check magnesium in those conditions as well, because the decrease in magnesium might be the factor for their decrease. Then magnesium increase, right, we already did in MgSO4 toxicity. So hypermagnesemia can lead to decrease in deep tendon reflexes, so patellar reflex lost, right. Also it causes lethargy, bradycardia, hypotension, cardiac arrest, and hypocalcemia. See, hypocalcemia can be caused by both hypermagnesemia and hypomagnesemia, right? Next we have phosphate. So a decrease in phosphate is associated with bone loss, then osteomalacia and rickets. Osteomalacia and rickets are the same diseases, with the difference being that osteomalacia is in adults and ricket is in children. While increased phosphate level is associated with renal stones, metastatic calcification, and hypocalcemia. So after electrolyte disturbances, we'll talk about the acid-base physiology, which is very important because one question is always asked from the acid-base disorders. Okay? So I'll give you a flowchart approach to this and you can solve any question by this flowchart. So we'll be ending today's discussion here only because a fresh mind is essential for understanding the next topic, that is the acid-base physiology. Hope you liked the video. Do send your feedback and any corrections you want to make to get featured in the next video. All your queries are welcome and you can comment or leave a DM on my channel, that is @Cramp Chronicles. Please share this video with your friends and do press the like button if you find this video useful. Your support is what motivates me to make content on a regular basis, so please help me reach a goal of 30 likes for this video. If I reach this goal, I shall post the next video by the end of this week itself. As always, subscribe if not already subscribed. Keep learning and keep aspiring. See you for the next video. Till then, take care and happy learning.